drug, the Australian Stroke Clinical Registry.
Hello everyone, thank you for coming. First of all, myself and co-authors have no disclosures to declare, and I would like to introduce Professor Dominic Cadillac, who is the custodian of the Australian Stroke Clinical Registry, who attend with us today. So women have reported to have greater on-cause mortality after stroke compared to men, but little is known about the sex differences in causes of death after stroke. This is also uncertain whether the sex differences in excess mortality rates attributed to stroke and other health issues among people with stroke and compared to the population norms. The current research is limited by the fact that many investigators fail to report sex-specific findings or fail to investigate the factors that contribute to the differences in causes of death between men and women, and the data were out of date. So our aims were to, among people with first ever stroke, we examine whether the causes of death after 1 year after stroke vary by sex, identify the factors that may account for any sex difference in causes of death, and calculate the excess mortality attributed to stroke and other causes compared to the general population. In these observational studies, we use data from the Australian Stroke Clinical Registry, OSCA as this is known, and this is a national registry to collect important information on processes of care in hospital and patient outcome. We included first ever stroke cases who admitted to 35 hospitals participating in OSCA during 2010-2013. The causes of death data up to 1 year were linked to the National Death Registration. Causes of death were categorized based on ICD codes as stroke, ischemic heart disease, other cardiovascular disease, cancer, and other conditions. The core information collected for the whole registry include social demographic, stroke type, stroke severity, which is indicated by the ability to walk independently at admission, processes of care, including stroke unit access, intravenous thrombolysis, care plan at discharge, and being discharged on antihypertensive agents. And some discharge information include length of stage and discharge destination. In statistical analysis, we use multi-level computing risk modeling to estimate female to male specific hazard ratio of causes of death, specific death rates in the general population by age, sex, and calendar year was calculated. Expected deaths for each sex were calculated by multiplying age-specific person years of observation in stroke population by the death rates in the general population. And we also calculate standardized mortality rate of the observed to expected number of deaths for each causes of death separately for males and females. So far, there were 9,411 first ever stroke events, slightly more men than women. Women were about 7 years older than men, and they were less likely to walk independently at admission, which is a proxy for stroke severity. In terms of evidence-based processes of care, we have found that there were no statistically significant difference between men and women in receiving treated in stroke unit, intravenous thrombolysis, discharge on antihypertensive or care plan at discharge. However, women had greater on-cause mortality up to 1 year after stroke. And stroke and other cardiovascular disease are the main causes of death after stroke, which accounting for over 50% of deaths. However, the distribution of the causes of death differ by sex, with women having more stroke due to stroke and other cardiovascular disease, while men having more deaths due to ischemic heart